After completion of all modules regarding central lines, you will be able to identify the standards of the Infusion Nurses Society with infusion therapy and specifically how they relate to Accurate Home Care. You will be able to identify policies and procedures of Accurate Home Care regarding infusion therapies. You will be able to identify the different centrally placed venous catheters, which include PICC lines, tunneled centrally placed catheters, and implanted ports, and identify complications and troubleshooting strategies for venous catheters. You'll learn about a few common IV therapies, indications for therapy, methods of delivery, and some infusion equipment. As part of your skills component, you will also complete a central venous catheter dressing change. As far as scope of practice, all nurses working with infusion therapies need to have knowledge of anatomy and physiology, skills necessary for administration of infusion therapies, and knowledge and judgment. Remember, nursing is always an independent profession, and you have the ultimate decision in terms of whether or not you do something. LPN scope of practice is dictated per state, but additionally, Accurate Home Care has requirements or prohibitions for LPNs to complete. At Accurate Home Care, LPNs cannot give any chemotherapy, administer narcotic pain medications or blood transfusions or other blood products, no IV push medications, administration of GCSF, central line clearance techniques, or calculating and adding medications to IV fluid containers. Additionally, there are state-specific guidelines that as an LPN you should be familiar with. In Minnesota, an RN can delegate IV therapy to an LPN with appropriate training. In Iowa, an LPN is not allowed to perform midline or PICC line therapies unless there is evidence that they have completed the board-approved education regarding IV therapy. In Illinois, LPNs may work with peripheral IV lines, but no central line therapy or IV push administration. And in North Dakota, LPNs need to complete a board-approved nursing program, which includes IV therapy or a standalone board-approved course in IV therapy. When it comes to vascular access devices, what we see most commonly at Accurate Home Care are short-term devices, so sub-Q administration, short-term peripheral IVs, and PICC lines, or peripherally inserted central catheters. The long-term devices that we see most common are tunneled catheters and portacats. Both short-term and long-term devices require you to be familiar with and practice aseptic technique, complete scheduled dressing changes, and remember that your role in the home is to prevent infection, tissue damage, embolism, and infiltration primarily. Your Elsevier modules will explore additional complications and troubleshooting. So what's the best way to prevent infection? You already know, it's hand washing. Wash your hands for at least 20 seconds. So think about the steps to hand washing. You get your hands wet, you get soap, you rub and scrub for 20 seconds, or humming the happy birthday song twice. You rinse your hands, and then you dry them with a clean towel, using that towel to turn off the faucet. Maintain sterility as required, and think about that again in the home care environment, that we don't always have a perfect sterile field to set up, but what can we do to minimize the risk to our patients? Make sure that pets are out of the room, make sure that windows are closed, that fans are turned off, and try to create the cleanest environment possible. So exploring some of those short-term vascular access devices, sub-Q. Sub-Q administration would be done with a butterfly or scalp vein needle that would be placed into the fatty layer of the skin. It's faster than oral but slower than IM or IV absorption, and typically a bolus or a continuous of 2 mL per hour or less, so very slow infusion. The site needs to be changed frequently, and some of the concerns are lack of absorption, occlusion, and skin irritation. You see in this photo here, this individual has 4 different infusions running subcutaneously. What we see most commonly in home care are IgG treatments and insulin administration. A peripheral IV is defined as the tip beginning and ending in an extremity, with the catheter being less than 2 inches in length. That's indicated for short-term therapies, and the pH of the medication being administered must be between 5 and 9. Remember that the pH of blood is right around 7, and so it needs to be not too acidic and not too basic, and that information would be found in conjunction with the medication prescribed. The site needs to be changed every 48 to 72 hours. Can be saline or heparin locked, and infiltration and phlebitis are some common complications. A PICC versus a midline. The tip of a PICC ends in the distal third of the superior vena cava, so very close to the heart, which makes it a central venous access device. The midline tip actually ends in the peripheral vein, so it's considered a peripheral device and is not a central line. The risk of phlebitis is lower with a midline than it is with a short peripheral catheter. So why is the PICC line placed there in that lower 1/3 of the superior vena cava? Why not further up in the superior vena cava, or why not lower in the inferior vena cava? Well, there are two reasons. Number one, the blood flow. As you get closer to the heart, blood flow is greater, which helps to prevent irritation of the vessel. Number two, the vessel gets stronger and the vessel wall gets thicker as it gets closer to the heart, and so again, preventing irritation from vesicant medications. There are several other insertion sites that may be used. They're illustrated here. The red dots are the where the tips would be located, so the superior vena cava here, or the inferior vena cava. The inferior vena cava would only be used with the femoral approach. Fairly uncommon to be seen in home care. Obviously not the best area for a central line to be located, but it is utilized sometimes. So most commonly we're going to see cephalic, brachial, occasionally subclavian or jugular veins as well. Short-term vascular access devices include valved and non-valved PICC lines. A valved PICC line will use a push and pause technique for flushing, and we'll explore that a little more. It may require saline or heparin flushes, but what's unique about a valved PICC is that the tip of the valved line has a three-way valve, so it acts like a saloon door to open and close. So when there's no pressure on the line, it'll default to that closed position. When you push on the line or put positive pressure in the line, it'll open into the bloodstream to allow the infusate to go through. When you release the pressure, it defaults again to that closed position. And when you pull a negative pressure or draw back on your syringe, it opens into the line and allows you to withdraw blood. So again, it defaults back to that closed position, and that prevents backflow and therefore prevents the need for clamps or a lot of times heparin locks on that line. So by looking at your patient's line, if they don't have a clamp, it's most likely that they have a valved PICC line. A non-valved PICC line will have a clamp to stop backflow. That clamp is going to hold a positive pressure in the line so that blood can't flow back into the line. Additionally, heparin will be used to prevent clots in the line. So how do I know if a line is safe to use? It's very important that you complete assessments each time you're using the line. You'll be measuring arm circumference and line length at a regular interval. You need to understand your orders, and you need to assess your patient for pain, signs and symptoms of infection, and resistance with the flush. It's important for you to learn what's normal, how a flush should feel for your patient. And then you'll be able to identify if a clot is starting to form or if the line is starting to become occluded. It'll start to feel sluggish or a little harder to push, and it's better to take a very proactive approach with those things than to have the line become completely occluded. You may use an extension set with a vascular access device. They come with clamps, but you can remove that clamp if you need to. They're not included as part of a dressing change kit, so you'll have to remember to get that ready if you need it, and you'll also need to prime the tubing before you attach it to the line to prevent air introduction. You may also use an antimicrobial disc to reduce the risk for infection. You'll see this in the other Elsevier modules, but some of the examples here are a BioPatch, an AMD patch, or a Silverlon patch. So there's more information here on each of those. An AquaGuard is one item that can be used to protect the central line during a bath or shower. Patients with central lines should not go swimming. That's a risk for infection. However, it's realistic that the patient will need to bathe. An AquaGuard is one approach. However, in home care, we don't always see those. Sometimes we just use saran wrap, tape, and whatever we can to protect that site. Again, it's not a waterproof or fail-proof mechanism to protect it, but it's something that we can do to prevent that. You also would plan for a shower before a dressing change if that's needed. When flushing a central line, you may be instructed to pull back on the flush to break the seal and remove air from the syringe. Evidence-based practice is always improving, and we have heard some recommendations that you simply push to break the seal on the syringe. So stay tuned if we need to update that information. We recommend that you flush with a push-pause technique. So that is to say, when you're holding a syringe in your hand, you push about 1 milliliter and pause, push another milliliter and pause, and with that gentle pulsing method, you're going to create turbulence inside of the line to help to clear any biofilm that's accumulated inside of the line. So again, using that push-pause technique anytime you're flushing is an accurate company standard. If you're meeting resistance or you can't get a blood return, make sure you complete your assessment and contact the physician as needed before administration. So as you are flushing, you want to think about SASH. SASH stands for saline, administer, saline, heparin. So you'll be scrubbing the hub, you'll be push-pausing your saline flush, scrubbing the hub again, administering whatever it is you're administering, whether that's a push medication, TPN, an infusion, an elastomeric device, and then when that's finished, scrub it again, connect the saline, push pause that saline, scrub it again, connect the heparin, and push that heparin. So again, for patients who don't have heparin, then we would just eliminate that step, but anytime you're accessing the line, you want to think about SASH, saline, administration, saline, heparin. So now talking about long-term vascular access devices. Tunneled catheters include Hickman or Broviac. Those are just a couple of brand name catheters. And then implanted ports or portacats. All of these long-term vascular access devices are surgically inserted by a physician, so they also need to be surgically removed by a physician. Tunneled central catheter is surgically placed, and patients can be taught self-care. It's okay to remove sutures after about 2 weeks of central line placement. Obviously, you'll have an order for that. And tunneled central catheters are a great access for blood draws. They're held in place internally by what's called a Dacron cuff that secures the catheter. So as the catheter is placed under the skin, a tunnel is created through the subcutaneous tissue, and then the catheter is placed in, and this Dacron cuff, over time, the subcutaneous tissue grows or adheres to the cuff, and it becomes an internal stabilization. When a patient has a line removed, scalpel is used to kind of carve up the line, and then they actually have to cut out a small amount of tissue around that cuff, which has become adhered. It's reassuring for you to know that they're fairly well secured. However, the line itself can still break. So obviously you need to be very careful with patients who have lines. We never recommend safety pinning to a shirt or anything like that because those lines could become damaged. Cap changes need to be completed twice weekly if patients are receiving infusions, and every 7 days if the patient is not receiving infusions. You need to cleanse the cap for 30 seconds with an alcohol prep every time you're connecting to it. So like I said with that SASH technique, scrub, scrub, scrub for 30 seconds before you give the flush. Our Elsevier modules do recommend 5 seconds. It's always better safe than sorry, and explain to the patient why you're scrubbing for so long, because it's a chance to reduce infection, and we want to take every opportunity we can to limit our patient's risk. You should also change the cap for every blood draw or when blood is present in the cap, and with any signs of leaking or dysfunction. There are also a fairly new device on the market, passive disinfection caps. There's a couple different brand names. One is the swab cap that you see here, another is a Kuros cap. They're single use, and they bathe the end of the cap in 70% alcohol. It protects the line from infection between accesses. It has to be on for at least 5 minutes in order to be effective, but it can be left into place up to 7 days if it's not accessed. So they would be thrown away each time. Again, they're single use. But there's no need to use any other additional alcohol scrubs immediately after removal. So you could take off that cap and immediately connect your saline to do your flush. You would then scrub in between administration, saline again, heparin again, because as I said, they need to be in place for 5 minutes in order to work. But really exciting evidence-based practice. There's a study now that I just received the other day that showed a 40% reduction in the rate of patient infections in a hospital where this was studied. So very exciting opportunity, and we may be seeing these more frequently in home care. So let's review. What are the 4 main differences between PICCs and tunneled catheters? Location. So are they located on the core or in the periphery? Long-term versus short-term. PICCs are intended to be in place short-term. Tunneled catheters are long-term. Stabilization. PICCs are externally stabilized, as you'll see in your Elsevier module, and tunneled central catheters are internally stabilized with a Dacron cuff. And finally, placement. PICCs are placed at the bedside by specially trained nurses or interventional radiologists, and tunneled central lines are implanted surgically by a physician.